Hi everyone, welcome back to our WVS webinar series. Today we've got our lovely vet Dr. Gowrie talking on procedural sedation in small animals, and I will hand directly over to her now. Thank you. Bye.
Hello everyone, my name is Dr. Gowrie Thade. I'm a veterinarian here at WVS Ooty, and our presentation today is on procedural sedation in small animals. So, what is procedural sedation? Basically, it is the use of sedatives, opioids, dissociative agents, and other drugs to facilitate patient comfort during short or mildly painful procedures. Examples of these procedures could be diagnostic imaging, urinary catheterization, like in a block cat, sampling, whether it's FNAC or an ultrasound guided biopsy, wound cleaning, bandage changes, laceration or wound repairs, IV, even sometimes IV catheter placements or physical exam, nail trim, ear cleaning can be really difficult in a aggressive dog. So we would need some level of sedation for these. So before opting for sedation, patient assessment is of utmost importance. This includes a thorough history and physical exam. Breed sensitivities, age, size, temperament of the animal also need to be taken into account. Diagnostic workup will vary with each patient, but CBC and biochemistry can be considered as minimum. The ASA, the American Society of Anesthesiologists, have made a scale for scoring human patient status prior to anesthesia. This scale has also been adapted to veterinary patients. So, the chart that you see on the right, ASA status 1 is for a healthy animal with no underlying disease. The ASA status 2 is for a patient with mild systemic disease like maybe a mild anemia or dehydration. Um, Even healthy brachycephalics are considered to be ASA status 2. ASA status 3 is a patient with severe systemic disease, and status 4 is a patient with severe disease that is at a constant threat to life, like unstable renal disease or a block cat. Status 5 is given to those patients that are not expected to survive without the procedure, like GDV or severe trauma. And the letter E, in addition, denotes emergency. So, determining an ASA status for each patient will help us plan the anesthetic protocol and anticipate the level of risk. This paper signifies the importance of a thorough physical exam. So, a group of anesthetists determined an anesthetic protocol for ASA status for patients after a review of history. But when they did the physical exam of these patients, the initial protocol was altered in almost 25% of the cases. And in around 8% patients, they were assigned a higher ASA status after the physical exam. So, this basically highlights the importance of a thorough pre anesthetic clinical exam. Before we opt for what drugs to choose, we need to determine the sedation level and duration. So, sedation can be of three levels: mild, moderate, and deep. For mild sedation, basically, we're just reducing their anxiety or excitement, but they are still very much in dorsal recumbency and they are not, they do respond to stimuli. This is basically for non painful procedures like a physical exam or a blood draw or just grooming. For moderate levels of sedation, they are responsive to auditory and tactile stimuli, but they are recumbent until we try to reposition them and then they can reposition themselves. They are still able to maintain their cardiorespiratory function. This is indicated for imaging like ultrasound or 2D echoes, or maybe an IV or a urinary catheter, or even a bandage change. Deep or profound sedation is when the response to painful stimuli is weak but still present. They are in lateral recumbency and they cannot shift themselves to the other recumbency. And there is a possibility of cardiovascular and respiratory depression. So, usually, in, say, ultrasound guided biopsies of abdominal lesions, or maybe oral or otoscopic exams, ear flushes, laceration repairs, or CTs or MRIs, we would need a deep sedation. Now, before we go to injectable drugs, we know that stress, anxiety, and aggression can lead to a higher blood pressure, heart rate, oxygen demand, and even overheating and respiratory distress in some cases, which can in turn contribute to morbidity. Having oral pre medication on board can be very helpful in some cases. For example, now the examples of these are trazodone and gabapentin, which are most commonly used. Trazodone is a serotonin receptor antagonist and a reuptake inhibitor. It is basically an anxiolytic, and when used prior to general anesthesia, it reduces the MAC of isoflurane by about 17%. So it is quite anxiolytic and almost as a sedative also. The doses mentioned here are only for one-time use prior to visit to the vet. Trazodone as a drug for a long-term use has different dosage. It is to be avoided or used with caution in combination with drugs that are serotonergic, like metoclopramide or fluoxetine, amitriptyline, because that can cause serotonin syndrome. So we have to be careful about that. Usually, trazodone is used more in dogs. It can be used in combination with gabapentin as well. Gabapentin is an anxiolytic mainly used in cats, and it is to be given around 3 hours prior to visit. It does cause some level of sedation at the higher doses where it is used as an anxiolytic. Alprazolam can be considered when you have reached your like a top of your maybe a trazodone, where you're worried that they may have serotonin syndrome. Alprazolam is a benzodiazepine. It's fast acting. It's a tranquilizer. And the doses mentioned here are just for a one-time use prior to the vet visit. Right now in the market, there is also aspromazine tablets, which also can be considered, and the feline facial pheromone, Felive, can also be considered for minor procedures in cats, like maybe an ultrasound or an IV catheter placement. Talking about injectable drugs, the drugs can be divided into three categories. There are sedatives, which are aspromazine, dexmedetomidine, midazolam, alfaxolone, propofol, and zenalpha. Then there's opioids. Butorphanol, buprenorphine, and fentanyl is what we have available here. We do not have methadone or hydromorphone available in India right now. Then there are dissociative anesthetics like ketamine and Zolotil. So aspromazine is a dopaminergic blockade drug, which is from the phenothiazine drug class. It is also an alpha 1 receptor antagonist and thus can cause vasodilation and hypotension. The onset of action is around 20 minutes approximately, so it's a longer onset of action when given intramuscularly, and the duration is also quite long. It's around 4 to 8 hours. It has anti-emetic properties, and when used at lower doses for procedural sedations, which would be about 0.01 to 0.02 mg per kg intramuscular in dogs, usually the cardiovascular and respiratory stability is maintained in the animals. Although it can still cause hypotension, it is very minimally respiratory depressive. Now, there are some contraindications, such as in boxers. There are some anecdotal reports of the boxers becoming hypotensive and collapsing after aspromazine, but you can still use it in lower doses. In dogs which have MDR1 mutations, such as your herding breeds, like Border Collies and Australian Shepherds, aspromazine is contraindicated because it can reach toxic levels in your central nervous system because of a defective transport mechanism. It is also contraindicated in liver disease, coagulopathies, and hypotension. Dexmedetomidine is an alpha 2 receptor agonist, which has an approximate 5 to 15-minute onset of action after IM injection. The duration is 40 to 90 minutes. In cats, there is a high incidence of vomiting. In fact, it is used as an emetic in cats, but when combined with butorphanol and at proper doses, it can be used as a sedative. There is a biphasic blood pressure response, same as in the case of xylazine, wherein for the first 40 minutes, your animal will be hypertensive, after which your animal will be hypotensive, and throughout the duration of sedation, your animal will be bradycardic. Um, Although there is minimal dose dependent respiratory depression. So, your contraindications are cardiovascular, respiratory, liver, and kidney disease, shock, and then very young and very old animals. The doses mentioned here are intramuscular doses. If you want to use it intravenous, it has to be at a lower dose, usually 1 to 3 microgram per kg. IV is what people prefer. It is reversible with atipamezole. Zen alpha is a combination of an alpha 2 receptor agonist, which is medetomidine, and a peripheral alpha 2 receptor antagonist, which is vatinoxan. So basically, the medetomidine acts in on the central nervous system to produce your sedation and analgesia, whereas the vatinoxan acts as an alpha 2 receptor antagonist on the peripheral blood vessels to prevent severe hypertension and reflex bradycardia. So in this drug combination, even though you get the sedation and analgesia, your heart rate is still maintained at an almost normal level. It is a quick onset of action, around 5 to 15 minutes post intramuscular injection, and duration is 45 minutes. Zen alpha was introduced as a standalone drug for procedural sedations, only for use in dogs, and the dosage chart that you're seeing is according to body surface area. So your dose rates per kg change; they reduce as the dose as the weight increases. Um, Zen alpha is currently not available in India; it's not launched, but hoping to see it launched soon. Then we'll go to a benzodiazepine, which is midazolam. It acts on GABA A receptors. It is a sedative and a muscle relaxant. It is not an analgesic. Onset of action is around 15 to 30 minutes post intramuscular injection, and duration is around 2 to 6 hours. In healthy animals, sedation with midazolam alone is not advised because it causes paradoxical excitation, and even when combined with an opioid, it can still cause the animals to become a little excited, or it may not give a proper level of sedation, which is why it is mostly reserved in sick or compromised animals, wherein they already have some mental depression. So this works to be better, and also because there is almost no cardiovascular depression and very mild respiratory depression with midazolam. Contraindications are severe liver and kidney disease. You can still use it, but with dose adjustment, and you do not use it when there's respiratory compromise. It is reversible with flumazenil. Similar to midazolam, there is also diazepam, but because this is a lecture about procedural sedation, midazolam can be given intramuscular, whereas for diazepam, you would need an IV catheter and give it intravenous, but you can still use that. Alfaxalone was recently launched in the market by the company that is actually written on the picture that is on the screen. It is available in India. It is a GABA A receptor agonist. It is not analgesic. It is very, very similar to propofol. But the only thing is it can be used intramuscular, which is currently off label for the multi dose vial, but people do use it intramuscular. Duration of action is short, it's around 5 to 10 minutes. It is usually used for achieving a deeper sedation or to prolong your duration of sedation. As a top up, there is hypotension, and rapid administration can cause apnea. Contraindications are in severe cardiorespiratory disease, very young animals, hypovolemia, and shock. And the dose depends on what combination of drugs we're using it with. It can also be used as a standalone induction drug, but the doses are very high. So usually it can be used in combination with the opioids and alpha 2 agonists. Then, of course, there is propofol, very similar to alfaxolone. Only thing is, propofol can only be used intravenous, and it can be used as a top up to or prolong the duration of your sedation. Opioids, right now we have butorphanol and buprenorphine fairly easily available in the Indian market. Butorphanol is a mu antagonist, kappa agonist, which is more of a sedative and minimal to no analgesic effect at all. The duration of sedation is up to 2 hours, and the duration of analgesia is 1 hour. Whereas buprenorphine is a partial mu agonist, which is more of an analgesic than a sedative, and the duration of analgesia is 6 to 8 hours in dogs and can go up to 12 hours in cats. With opioids, there's always a ceiling effect, meaning the dose that you have given, if you do exceed the dose, your level of analgesia will not improve. You would either need to use another analgesic, basically that, or if you need a higher level of analgesia, you could consider a pure mu agonist like fentanyl. Ketamine is a dissociative anesthetic. It is an NMDA receptor antagonist. Usually, it is administered with other sedatives and opioids to achieve a deeper level of sedation. It is a cardiovascular stimulant, which is different to all the other anesthetic drugs that we use. Spontaneous respiration is usually maintained in animals, and the onset of action is 10 minutes from IM injection. Duration is up to 20 to 40 minutes. It is contraindicated in severe organ dysfunction, or if the animal is already hypertensive or tachycardic. If it is epileptic, if there is glaucoma or head trauma, it will increase the intracranial and intraocular pressure. So it is contraindicated in those conditions. A dose is around 3 to 10 mg per kg IV or IM. Zolitol or tilazol is a combination of a dissociative anesthetic, which is tiletamine, and a benzodiazepine, which is zolazepam. It is fast acting, and there is minimal cardiorespiratory effect. In dogs, the duration of action is shorter. It's around 10 to 20 minutes. And in cats, it's longer. It's around 20 to 40 minutes. The zolazepam in the Zolitol combination is reversible with flumazenil, but tiletamine is not reversible. So how do we choose what drugs we use for sedation? This chart is from the 2020 AHA Anesthesia and Monitoring Guidelines. It gives us an idea of the drug combinations that can be used for light, moderate, and heavy sedation in healthy and compromised or sick animals. So for a light sedation, an opioid alone or in combination with a benzodiazepine is usually sufficient. For a moderate level of sedation in healthy animals, a combination of dexmedetomidine and an opioid or acepromazine, or an opioid or acepromazine and an opioid is preferred. But for sick animals, you would still stick to a benzodiazepine and an opioid, but at slightly higher doses. And when we want a deeper sedation, you would either add ketamine or alfaxolone to the mix. Whereas in sick animals, dexmedetomidine is avoided. An opioid, a benzodiazepine, and either a ketamine or alfaxolone combination is preferred. Your ASA physical status can also help you determine your drug protocol. You can note here that as the ASA status increases to 3, 4, or 5, The use of aspromazine and dexmedetomidine is not recommended due to their ability to cause cardiovascular depression and hypotension. The same, the case is same in cats as well. So, when you are optimizing for a successful sedation, usually oral pre-medication prior to visit in very anxious or aggressive animals can help the animals also to reduce stress and anxiety, and can help us also in handling. It will also help reduce the drug doses required for sedation. Um, when you are loading the drugs, it is always easier to add drugs to your protocol than to subtract them. So, titrating drugs to effect will help in reaching the desired sedation level. To minimize stimulation, you have to control the environment in which the animal is being sedated. So, try to use quiet and comfortable spaces and dimly lit rooms without much footfall till the sedation kicks in. You can also consider plugging their ears with cotton plugs and using eye covers if they are comfortable. Individual reactions to sedatives are very different, so always plan for different outcomes of sedation, including general anesthesia and anesthetic complications. So, an animal which has a light level of sedation with a certain drug dose, if you use the same drug dose for another animal, it is possible that he may go into a deep sedation or even need intubation. So, you should always be prepared for that, and keep equipment for intubation and emergency drugs and reversals always accessible and in some cases pre-filled. This chart is from the 2025 ACVA anesthesia monitoring guidelines. It gives us recommendation for monitoring required at different levels of sedation. A dedicated anesthetist who is always in contact with the animal is required for all levels of sedation. They would be tracking the physical parameters, which include heart rate, pulse rate, respiratory rate, anesthetic depth, mucous membrane, and capillary refill time. At moderate levels of sedation, addition of pulse oximetry and temperature is recommended. And at deep levels, blood pressure, ECG, and capnography should be monitored in addition to the rest of the parameters. So, here are some sedation scenarios. I will give you some options for drug combinations that you can use in these scenarios. The first one is a 2-year-old male neutered mixed breed dog with no reported comorbidities, which is presented for a non or mildly painful minor procedure lasting for a short duration. This dog will be classified as an ASA physical status 1. Your options for sedation would be aspromazine plus an opioid. Now, the thing with aspromazine is that the duration of action is slightly longer. So, if it is a shorter duration, you can consider giving a lower dose of aspromazine. It also does not have a reversal, so you need to keep that in mind. Your second option would be dexmedetomidine plus an opioid. The duration of action is not very, very long. It's about 40 to 90 minutes. And the opioid will obviously depend on the amount of analgesia that you need. Your third option would be Zolotil and with or without an opioid. And your fourth option would be Zen Alpha. Our second scenario is a 5-year-old female spayed French bulldog with no reported comorbidities, which is presented for a laceration repair. So, for a laceration repair, we would need a moderate to deeper sedation. This dog will be classified as an ASA physical status 2, even if it is healthy because of all the anatomical defects that brachycephalic breeds have. Oral pre-medication, if indicated, should be used. Brachycephalics, it is always recommended to pre-medicate them with maropitant and metoclopramide, or even if you only have metoclopramide, that's also fine. That is because they have gastroesophageal reflux, which is very common in them, which can cause aspiration pneumonia. So we do not want them to reflux. Always pre-oxygenate these dogs. This is because we are assuming that if they need intubation, the time to intubate this dog would be slightly higher than what a normal dog would need. So the chances of oxygen desaturation are quite high. So pre-oxygenation will give us about 5 times the amount of time that uh, would need to desaturate this dog of oxygen. So we will get more time to intubate the dog basically. Because these dogs have a high vagal tone, always keep your anticholinergic pre-filled and ready. That is either atropine or glycopyrrolate. Your options for sedation are either a low dose acepromazine along with an opioid, with or without a benzodiazepine. So acepromazine in these dogs at lower doses, around zero point zero 0.01 to zero point zero 0.02 mg per kg intramuscular, can help reduce their respiratory distress. It can help in a little bit of vasodilation, which will help in cooling. And acepromazine is also antiemetic. um, your second option would be dexmedetomidine with an opioid. You can also consider local block or an infiltration block to provide additional analgesia. If you need further sedation, you can consider propofol or alfaxalone, as these are very short duration, but you have to keep in mind that these are also respiratory depressants, so you need to be prepared to intubate. With all brachycephalic breeds, you need to monitor their pulse oximetry at all times, and always keep a lower size of the ET tube ready. If you intubate them, you should keep them on 100% oxygen and be ready to ventilate them if they need. If you do intubate them, then the extubation should be delayed. Monitor pulse ox at room air before extubation. So once your procedure is done, you can detach them from the oxygen and keep them on room air with the tube in place, and then see if they're able to maintain their pulse ox above 95%. You can go ahead and extubate them. If they are not able to maintain that, please oxygenate them for a little more time, and always be ready to re-intubate these dogs, because sometimes the animals are not able to breathe because of the excess tissue that they have in their necks. If that happens, you may need to re-intubate and possibly keep them with the tube in till the level of swelling goes down. You can consider giving a steroid at that point to reduce the swelling. So basically, with brachycephalics, just be ready for general anesthesia. Our third scenario is a 10-year-old female spayed DSH cat with reported cardiovascular compromise, classified as ESA physical status 3, and is it presented for a sedated oral exam. Uh, Before trying to sedate this animal, you always have to determine the nature of the heart disease and whether or not it is safe for sedation. So if she does have heart disease, which is usually commonly either hypertrophic cardiomyopathy or dilated cardiomyopathy sometimes, if they need to be on medication for the heart disease, they should be on that medication. And we should just make sure that their heart parameters are fine. Our main aim is to maintain the heart rate while and blood pressure while they are under sedation. Our safest option for sedation is an opioid along with a benzodiazepine, because both of them are very minimally cardiorespiratory depressive. You can also add alfaxalone if it is intramuscular that you're giving it, or propofol if it is IV. But just be careful that both of these drugs are hypotensive, and always oxygenate these animals. Our fourth sedation scenario is a 1-year-old male neutered Pomeranian dog involved in a road traffic accident, presented with a large open wound on the hind lip. This is classified as ASA physical status 5. That is because without any kind of intervention, this dog would die. So your options for sedation are either opioid only or opioid and a benzodiazepine. Or if you need additional analgesia, you can use ketamine. Ketamine can be used at sub-anesthetic doses, so around 0.5 to 1 mg per kg, IM or IV, uh, and then follow it with a CRI. Or if you need sedation, you can use it at a higher dose. Before doing all of that, of course, you have to stabilize the dog, make sure he's not hypovolemic, he's fluid resuscitated, and the shock is treated. Our fifth sedation scenario is a 2-year-old male neutered domestic short-hair cat presented with a urethral block. This one is classified as ASA physical status 4. Uh, Before sedating this animal, again, you have to stabilize the animal. You have to make sure it is fluid resuscitated and that electrolyte imbalances are corrected, especially hyperkalemia. If you need to, if the bladder is too distended, try to do a cystocentesis before you opt for sedation. Your sedation options are opioid along with a benzodiazepine, and usually ketamine is added to the mix, even if the animal is azotemic. This is a post-renal azotemia, so adding ketamine should not be a problem here. And then, of course, you can give propofol to effect. One more thing to add here is a sacrococcygeal block, either with lidocaine or bupivacaine. Ideally, bupivacaine because it is longer acting, which will help in analgesia. These are some of my references. And yeah, thank you.
Thank you so much, Dr. Gary, for that amazing presentation. It was so thorough and really detailed and very practical as well. I always appreciate that it's got real proper practical application. So I hope everyone takes that on board. And it was just so good to consider all the context of everything, specifically pain. That's so important to consider. But the environmental context, it just was really, really detailed. So thank you. And thank you all for watching. If anyone has any questions, please just pop them into the chat now and we'll do our best to answer them. But whilst everyone is doing that, I just thought it'd be worthwhile mentioning that we've got 2 QR codes on the screen now. One of them takes you to the WVS Academy website, which we have so much content on loads of different diseases and really useful tips and tricks and practical content for being a vet. So please check that out. Also a vet nurse. And then the YouTube channel QR code takes you to where we've got the rest of our webinar in the series that we've been doing. So there's quite a few on there now. So if you want to do any CPD and check out the other videos, please do. And this webinar will also go onto the YouTube channel afterwards as well. So thank you. And we will have more in the series, I'm sure. I will definitely be getting you back, Dr. Gary. But in the meantime, I thought it would be really interesting to also get your opinion on how you would manage a cat or a dog that comes in with dyspnea, what you would sort of be thinking in your head in terms of a sedation protocol for that animal. I know that's a very broad thing. There's lots of things that could be causing dyspnea, but maybe you could just go through some of your thought processes and why you might pick certain drugs over the others.
Yeah. So for dyspnea, I mean, yes, you're right. It depends on why the dyspnea is happening. If it is something that needs intervention, that comes first. But before that, it is important to oxygenate any animal which is coming in dyspnea. Usually, because they're so agitated, an oxygen cage would be your best option. But even if you can manage a mask, that would be ideal. If not, then you can still use nasal prongs if the animal is able to tolerate that. My drugs of choice, honestly, the first thing would be butorphanol, because it is a sedative. Basically, we have to sedate the animal so that it is able to ventilate itself better. With a higher rate of respiration, it is really difficult for the animal to ventilate itself. So even if we provide oxygen and they're still breathing really fast, they will still not be able to oxygenate themselves. So usually, intramuscular butorphanol would be my first option. If it is a brachycephalic coming in respiratory distress, butorphanol along with acepromazine would be my choice. Mainly because, like I said, acepromazine is a great tranquilizer, uh, and at low doses, it will work great for vasodilation, which will help in cooling the animal. And if after the sedation and the oxygenation, if it is something to do with intervention, then you go ahead and do that. Like if you need to take out air or pus or whatever out of the animal's chest, then you do that.
Okay, yeah, that's super helpful. Thank you so much. And yeah, it was very broad, so there's lots of things that might also need to be done in that situation. We've got a couple of people commenting. So in terms of getting hold of the presentation, you'll just be able to find the recording of this either through the link that you already came through on or onto our YouTube channel. Don't actually have the PDF available. You'll just have to find the recording of the webinar. Somebody's asked about information about oral sedatives. So maybe just a quick recap of the oral sedatives that you went through, the trazodone, the gabapentin, just so to summarize for that person, maybe they missed the start of the webinar.
Yeah, I think we can go back to that slide. Yeah, there it is. Okay, so trazodone basically as a tranquilizer, but just to remember that it is a serotonergic drug. It is an anxiolytic, and when you use it at the recommended doses, usually if you're going to follow it with a gas anesthesia, you should expect MAC reduction. So you would keep your gas at a lesser level. But since we're not going to gas here, if it's just a one-time pre-visit use, the doses are given on the screen. For dogs, it's around 5 to 7 milligram per kilo, 90 minutes prior to visit. And for cats is 50 mg per cat, or 7.7 to 15.2 mg per kg, again 90 minutes prior to visit. It can be used in combination with gabapentin. If you have an animal that you know is anxious or aggressive, and it needs to come into the clinic for a planned procedure, then it is always better to dose the gabapentin at a the trazodone at a much lower dose, say around 3.5 mg per kg, and then titrate upwards till you get the level of sedation and anxiolysis that you want. Then gabapentin, again, as a single dose. For anxiolysis, the doses are much higher, usually upwards of 20 or 30 mg per kg per oral, mg per kg or per os. Usually it takes a long time for the gabapentin to start acting, so 3 hours prior to visit. Again, if you're using it with trazodone, I believe the doses are around 5 mg per kg trazodone and 10 mg per kg gabapentin in combination can be used both for dogs and cats. And if you're worried about serotonin syndrome, you can consider alprazolam or acepromazine oral.
Thank you so much for summarising that again. I hope that covers everything for the person that asked. There's another question about ocular surgery. So I guess we are at this point, if you're talking about a cherry eye or an entropion surgery, such as you are, at that point that would be a general anaesthetics, but maybe you could just cover what you would give as a pre-medication prior to inducing.
Yeah. So for ocular surgeries, I guess you would just keep ketamine out of the combination. You would still be able to use your opioid alpha 2 agonists, and if you have to, you can use aspromazine as well. But usually, you would be able to then either use a combination of alpha 2 and opioid as a pre-med, and then induce with um, midazolam or diazepam, and with either propofol or alfaxilone.
Okay, perfect.
And
Thank
then,
you.
very important to mention local blocks. Wherever you can, always use local blocks, especially for any enucleation or anywhere that you can, because those
Yeah,
provide a lot of analgesia. Yeah.
yeah, I completely agree with that. Multimodal analgesia will really help to reduce the amount of anesthetic and sedation drugs that you have to use for any procedure. Somebody else has asked, could you please provide the source to get acepromazine in Andhra Pradesh or somewhere else? I'm assuming that's trying to actually purchase it. Do you read that the same?
Yeah, I think so. I think they want to purchase it. Uh, Acepromazine, hold on. Well, I forgot the name of the company, but there is one company which is providing acepromazine and atipamezole now. If they can leave their email, maybe I can find out and then I can revert back to them.
Perfect. That sounds good. Yeah, if you can pop your email onto the group chat, or if you don't want to share it publicly, maybe get in touch via our academy email address, and we will try and get back to you on that. So we've had a question saying, why isn't acepromazine used in WVS if it works for longer duration?
That is because, first of all, I mean, it does not have a reversal. That's one main reason why we don't use it. And secondly, the sedation is a little bit unpredictable with acepromazine. We are finding that with alpha 2 agonists, we get a better level of sedation, whereas with acepromazine, sometimes it's good, sometimes it's not that great. So, yeah. And we can always reverse the alpha 2. So,
Yeah, I also haven't really used ACP, which is aceprosamine, that recently. To be honest, I think it was used quite a lot a few years ago, and now that we are much more comfortable and confident with using the alpha twos, it seems that we've gone more that way. But thank you for summarising why, because I think it is just it's very predictable, and we can reverse it, which is a really handy thing to be able to do. So somebody has asked, if you can give a little guidance about safe and quick endotracheal intubation in cats, that would be really helpful. Thank you.
so with cats, because of laryngeal spasms, you have to give a little local anesthesia. That's about zero point 0.2 ml. So that's one drop on either of the arytenoid cartilages locally. And then you wait for it to act about 90 seconds or so before you intubate. And again, I mean, use a laryngoscope if you have to. And yeah, just the ET tube size, just make sure that you get that correct. Uh, they don't really need rapid induction as such, because you would be able to, like, you would not take so much time to intubate cats. But it is advisable to use lidocaine or lignocaine before you try to intubate. I guess. I hope that answers the question.
I think it does. I think,
I don't
yes,
know.
most clinics have access to the spray now, don't they? Which is the local
Yeah.
anaesthetic, so that you can
Yeah.
spray that into the back of the mouth and then wait 90
Yeah.
seconds before intubating. And I agree, using a laryngoscope makes your life so much easier, just as much
Yeah.
light as you can get. And
Yeah.
if you are struggling, if you can have flow by oxygen,
Yeah.
around the same time, that I think that takes the pressure off a lot.
Yeah.
So that would be my top tip as well, is just having oxygen, even if it's just flow by on standby. Somebody's asked, what are some of the most common mistakes you see in the field with sedation, and how do you avoid them?
Um, well, preparation for sedation is extremely important. So I feel like that is one aspect which we tend to overlook. We need to make sure that we prepare for any kind of anesthetic complications. And yeah, I mean, just when you're sedating the animal, don't think that sedation is safer than general anesthesia. It is not, because even if you're giving drugs at a decided dose, you don't know how the animal will react to it. Always be prepared for general anesthesia and be prepared for complications.
Yeah, I agree. I think one of my tips would probably be when you're in maybe a high pressure situation or you think you have to act quickly, making drug calculation errors can be really common. So even, just taking a minute to double check your calculations or ask somebody to check your calculations before giving the doses, I think that can just sometimes really save a potential mistake if you're trying to think about a million things at once or you're trying to get something sorted quickly. Is just take that extra minute or two to just double check something, make sure you've got all your equipment ready as well, and just take a breath before just barreling into something and then accidentally making a mistake where you wouldn't usually have done that if you had more time. Thank you, Dr. Sumanth, for providing the name of the company. That's really useful. And somebody's asked if we could repeat the question regarding ocular surgery, so perhaps they didn't quite hear. If you wouldn't mind just repeating the answer with what pre-medication you'd give for the ocular surgery question.
Ocular surgery, I mean, it's like a broader concept, but I'm assuming that if you do not want the intraocular pressure to go up, you would avoid ketamine in your induction. You could still use ketamine, I believe, as a sub-anesthetic dose for analgesia, but then I would usually use an opioid and an alpha-2 for pre-med, and then possibly a benzodiazepine and either propofol or alfaxolone for induction.
Thank you very much. And somebody's asked, what's the safest anesthetic protocol for brachycephalic breeds? So I do think you covered that really nicely with the scenario before, but maybe you could just do again a little summary in case that person missed what you were saying.
So there is no drug which is unsafe for brachycephalics as such, but I would avoid higher doses of acepromazine. So basically, you would use either a combination of an opioid and acepromazine. If you need more sedation, you could either add on alfaxolone or a benzodiazepine like midazolam, or you could use a combination of dexmedetomidine and an opioid. But when you're using dexmedetomidine, always just make sure that your anticholinergic, either atropine or glycopyrrolate, is pre-filled in case if the animal is bradycardic. In brachycephalics, unless the animal is already bradycardic, anticholinergics are not indicated. But if the animal is bradycardic prior to the sedation, you can use anticholinergics as a pre-medication.
Yeah, there's also lots of things you can do with brachycephalic breeds to make it as safe as possible. So Dr. Gowrie also spoke about how just having an ET tube on hand, because you might need to proceed to general anaesthetic, and making sure you've got that in a variety of sizes and smaller than you think, just in case the airway is smaller than you anticipated. You can pre-oxygenate, and also if you are having them on their back, having them at an elevation so that they can breathe more easily. That also really helps. And just as with all animals, being aware of their temperature and making sure that we're providing heat for them if they are their temperature is dropping is always really important as well. We've had a question about fasting protocols for sedation, whether this differs from general anaesthetic, whether or not we can proceed with sedation without fasting. I think that's an ever changing discussion, isn't it? And there's more research being done on that. But do you mind giving your experience in that situation?
The current recommendation, I believe, is same for sedation and general anesthesia. So basically, 4 to 6 hours of fasting for a healthy animal, no food, but water is not withheld at all. And if it is a very young animal in which is but they're usually prone for hypoglycemia, then we would not withhold food until about an hour prior to the sedation. Yeah.
Yeah,
I
I
think the
think that.
recommendations are the
Sorry,
same.
carry on.
No, I was just saying I think the recommendations for fasting should be the same. Yeah.
Yeah, this is my understanding as well, and I think until we know more, until there's more recent research, then I would go on those guidelines as well, and I think it's just important that if you know, using those hours can be really useful as well to stabilize a patient if they have eaten. Like you can't, they're not just hours that you have to sit waiting. Like often those patients maybe also need something else, whether that's fluids or oxygen, to make sure that they are their most stable before proceeding with the sedation. So I think always think about what else you could be doing to make the sedation as safe as possible. And it's not often that we need to rush into a sedation as well, and think about what other equipment you can use, diagnostic tools you can use in that time period. Whether, if you are wanting to get an x-ray, maybe you could consider instead doing an ultrasound scan, because a lot of the time we can perform those conscious. So just trying to think outside of the box, and proceed as safely as possible. Somebody's asked what are the pre-anesthetic protocols for a GDV surgery. So I think we're veering into lots of different scenarios now. So
Yeah.
if you can, that would be great.
Yeah. I don't think that's a procedural sedation at all. But I mean, yeah, maybe we can cover that in, maybe we can do a
Yeah, I
lecture
think that's
on
a good idea.
emergency. Yeah.
Yeah, maybe let's save some of those specific questions for
Yeah.
another webinar, and stick on topic.
Yeah.
Somebody's asked though, you haven't covered xylazine, and they're asking why. So whether or not you might briefly be able to discuss that.
Yes. So wherever I have mentioned dexmedetomidine, xylazine can be used instead of dexmed. But I just believe that dexmed is so much of a better drug, as in we get to see a lot less of the reflex bradycardia and the eventual hypotension that happens, that is much less in comparison to xylazine, but it is interchangeable. If you do not have access to dexmed, you can still use xylazine.
Yeah, hopefully you get access to it soon, because that would be wonderful. It's much safer. Somebody's asked, in cases where butorphanol is not available, can xylazine alone be used effectively for sedation?
Yes, it can be. It can be, as long as you don't need analgesia. If you need higher levels of analgesia, it's always better to add on an opioid.
Yeah, I completely agree. As with everything, at the forefront of our minds, it should be animal welfare, and that has to include adequate pain relief. So we shouldn't be performing painful procedures if we can't provide adequate pain relief in those cases. I think that is the last of the questions. So thank you so much, everyone, for watching, and thank you for engaging so well and asking so many questions. It's been a super good webinar, and good luck with all your sedations in the future. If you have any more questions that you think of, please get in touch, and look out for the recording when we post it on the YouTube channel, or you can just reuse this link that you've already used to watch the webinar live. Thank you so much, Dr. Gowrie. I really hope you come back and do some more for us.
Yes,
if anyone
definitely.
has any topics you want us to cover, again, please get in touch, because that would be wonderful, so that we can cover what's most important and what's most helpful to you all. Okay, we'll say goodbye then for now. See you next time. Take care, everyone.
Thank you.